question. And then it gets brought to the lab. They look for 3 genetic mutations, 2 RNA mutations and 1 DNA mutation. If it's negative, they test for these 3 mutations, the PRAME, the LINC, and the TERT. If it's negative, 99% it's not a melanoma. That's very helpful for me. So I can reassure them, today, it's not likely that that's a melanoma. We can just monitor it. If it comes back positive, then you've justified biopsying it. And I've had at least a dozen melanomas where that's been the case, mostly on the face, because who wants to get their face biopsied, right? No one wants to do that. So this is very helpful. So this is, exciting part of technology, right? These are things that I'm using on a daily basis to help patients. The problem with DermTech is there's no reimbursable procedure. So a lot of dermatologists aren't doing it. There's no money in it. But I do it as an adjunct because I think it's the right thing to do. So in conclusion, we've talked about topical steroids by potency and allergenicity. Hopefully you get some steroids you can bring back to use in your clinic on Monday. You'll pick the right vehicle and the right amount for the location and the job. We've gone through 4 common dermatology complaints. We reviewed some of what's new in dermatology. Hopefully you'll consider a dermatoscope and maybe a class, and reviewed some of the newer useful technology that I find in dermatology. So hopefully you can all leave with a pearl, and I'm happy to entertain any questions you might have, not just in this, but anything in dermatology. Yes?
We have a online question. Is there a billing CPT code for dermoscopy? Is the CPT code additional to the office visit E&M?
Well, there is not a CPT code for dermoscopy. So that is something you're just going to do out of the pure love and to be more accurate. So there is nothing for that. Now for the DermTech, you can bill a 99214 because the level of complexity is a little bit higher, so you can bill a higher level office visit.
Right.
So,
thank you.
Yes.
There we go. I just want to thank you for an awesome lecture. I've been to many lectures over the past 40 years on dermatology, and I want to congratulate PCOMS because all these speakers have been, you guys are world-class speakers. It's really
thank you very much.
Amazing. But I just wanted to ask you a couple just real quick questions. The one where you said the people who have had psychotic illness, whatever, have had a rash, whatever, I find the same thing. I do post-acute and long-term care. And every time I see somebody that has that rash, I check, and sure enough, they've been on an antipsychotic, and they've had this rash. And what I've found useful was ketoconazole. And I know that you've, topically, because I noticed that you said it was kind of they thought it was a fungal. And I usually put them on it for about 4 weeks, come back and check them, and it's usually been pretty helpful. So I don't know if you've ever done that or not.
Ketoconazole is good for maintenance. But I find if you just throw a mild topical steroid in there, it'll go away in a couple days.
Yeah, like Elicon or something like that.
Elicon's a little strong for the face, I think.
Okay.
If you go with Desonide or 2.5% hydrocortisone, start there. But and then there's combination drugs that you can have with the, Alcortin was one that had an antifungal as well as a cortisone together mixed in. But they're a little more expensive. So you can use ketoconazole like you're doing, that's fine. You may just throw a little steroid in there for a couple days to knock it down.
Okay.
Yeah, excellent point.
One other thing was very interesting. I've only ever seen it once. A man had a rash going down both sides of his cheeks. We've used all different things, didn't work. Sent him to a dermatologist. He took a biopsy, and he said it was really a cancer that was within it was like an injected little kind of appearance, and he never saw it in his life. He was a dermatologist. He said he was in practice 30-some years. First time he ever saw it. Wow. And so sometimes if things don't clear up, I am quick to refer them to a specialist. Like, I wish we had some like you in town, but just real quick, my grandson, he was 9 years old, fair skin, had a little dark spot on his right upper back. Took him to a dermatologist. Says, I don't think it's much, but if you want, make you sleep better, I'll biopsy. He biopsied it, and it was a significant it was not a melanoma, but it was a
Dysplastic nevus? Yeah.
it was significant dysplastic nevus.
Yeah.
So he was very glad that I insisted on the
Nice.
on the biopsy. So again, a lot of things. The clobetasol, if it's still limited to 2 weeks of use, because I know I
Yeah,
use that
I think
sometimes in
all
severe
steroids-
cases.
All steroids, a good frame of reference is 2 weeks on, 1 week off.
Okay.
Always take at least a week off.
And they claim never to use that. It's like Temavate, the brand name, never
Too
to
strong
use
for
it
the
on the
face.
face.
Too
right?
strong for the face.
Okay, I just wanted to check. And one other thing, I think I found that nobody in our town knew what this one lady has. Her whole body is red, dry red skin, and I think it may be that erythrodermic psoriasis that you talked about, but it's horrible when you walk into the room and look at it, and no one is. We've checked her out medically for all the medical conditions, but at least now I think I have an idea, and I'll mention it to maybe one of our dermatologists.
Awesome.
Now, where do you practice here in town?
Yeah, St. Pete, and
Okay.
Seminole, Clearwater,
Okay.
yeah.
Well, again, thank you so much. Excellent lecture.
My pleasure, thank you.
Thank you, Dr. Armstrong. This ends the formal lecture portion of the seminar, and now Dr. Fotopoulos will be coming in, and he'll be working with OMT. Okay? Thank you.
Thanks, brother. Appreciate you.
There you go. All right, thank you. Okay, so we're now going to begin our OMT session, and we have faculty is Dr. Thomas Fotopoulos. Dr. Fotopoulos earned his Bachelor of Arts degree in Biological Science from Florida Atlantic University, obtained his Doctor of Osteopathic Medicine degree from Nova Southeastern University, Karan C. Patel College of Osteopathic Medicine. Internship was served at Florida Hospital East Orlando, and later he completed a residency in neuromusculoskeletal medicine and osteopathic manipulative medicine at Osteopathic Medical Center in Texas, Fort Worth, Texas. He is board certified in neuromuscular medicine, osteopathic manipulative medicine. Prior to joining, now he's at the Alabama College of Osteopathic Medicine. And prior to joining, there he's social clinical professor of OPP at Arkansas College of Osteopathic Medicine. His previous positions, including chair of the associate professor, chair of osteopathic medicine rather, and a social clinical professor of OPP at Lake Erie College of Osteopathic Medicine. He is a second-generation osteopathic physician, enjoys teaching students to better understand and utilize OMM. He is passionate about teaching, is able to break down complex material into easily understood concepts. He has been honored with numerous Teachers of the Year awards throughout his career in medical education. He is a member of the American Osteopathic Association of Colleges of Osteopathic Medicine, Educational Council of Osteopathic Principals. His research interests include osteopathic medical education. Dr. Fotopoulos, thank you.
Well, thank you all. Thanks. I'm glad to be back here. I got a special treat. Do you have your microphone on?
They just put it on.
Okay. This is Dr. Taras Kokno. He is an MD, and he is a PM&R doc. And I met him many years ago before I left LECOM Bradenton. His son ended up going to LECOM Bradenton because Dr. Kokno really saw the value in being an osteopath and doing physical med and rehab. He was trained in Canada and worked with Bess Mason. Did a lot of muscular work and how the muscles worked and stuff. Very rare. He's a lot hands-on, just amazing with his technique. So we've collaborated, working on a lot of things together, and we just want to show you all some cool techniques and things that can help.
So what I've been, for the last 35 years, I've been in practice, and I've been fortunate to work with great people, with therapists, people from around the world, athletes. I have access to IMG, and a lot of it was learning my own applications and watching other people do it. To go back, I was trained as an MD. We didn't, DO wasn't really, everybody thought MD, go MD, MD. If you can't do MD, then try something else. But I chose PM&R because I felt that, you had the skills to work on people, but we never really were taught manual therapy. I was fortunate to go to Canada, where I chose to go to do residency. Dr. Bess Mason was there. He was the editor of Grant's Anatomy. He was the father of EMG studies. Wrote many books on rehabilitation. At the time I met him, he was 80. I was 25. So it's been a long time since he passed, but he was an Armenian immigrant who instilled in me the understanding that to be a good physician, you really have to apply your skills, and you have to do them well and with effort and concentration and experience, and know your limits. And every week he made us learn every muscle attachment, and how it made the body move. I thought it didn't apply to me. I became a PM&R, I wrote orders, and I was asked to be a medical director at IMG, Sports Academy, but I couldn't do anything. My chiropractors were doing it, my therapists, but they weren't doing it well enough. I got introduced to other people, Aaron Mattis, And eventually, LECOM came into town, and Dr. Fotopoulos came and elevated, my interest again. And my son was thinking of medical school, and I guided him to DO school, and we got him into LECOM, and now he has his own clinic. So after 35 years, there's some things that we had learned that my path and working with Dr. Fotopoulos kind of crossed differently, and it's something that we found was really unique. And our approach to working with our patients, athletes, car accidents, injuries, age, transcends pediatrics. I see 1-year-olds and I see 101-year-olds. And I work in a nursing home, and I do osteopathic alignment manual techniques there. So what do we want to bring you today to make it something new and exciting? Osteopathic medicine, chiropractic, they complement each other a lot. But what I looked for with Tom, Dr. Fotopoulos, but I'll refer him to Tom, that we refer to, well, what is different and what is unique, and how can we do things quicker, more efficient, and that's more sustained? So the more superficial you go in a system, like a muscle, whether you manipulate a small joint, whether you puncture it with a needle, whether you stimulate it with an E-stim, ultrasound, you're only getting the superficial layer. And that layer bounces right back. It's like a rubber band. You play with a rubber band, they feel good, they come back, it's the same thing. It's great for a business model because they'll always be coming back. But when you're dealing with people who want to be fixed or come down to see you for specialty, or you're starting to gather attention that you're doing something different, they want a response that's sustained and understandable. So how do we, well, should I tell them the 3 things we're going to do, or should I keep going into the history?
No, tell them the 3 things. But I want to say this, one person that we worked on, most amazing, had a stroke.
So we'll give you scenarios. What Tom is referring to, I had a very close friend. He had a stroke. And so with the stroke, you do a lot of therapy, you do range of motion. And you're doing range of motion, reducing spasm. And he really was overstimulated with E-stim to try to get muscles who weren't moving, and he was doing too much stretching in different planes and getting pain. So Tom and I asked Tom to join me and help me. And so my friend who had left-sided hemiparesis, and it was a weird one, and it inflamed all the muscles. Now, the reason I say it was inflamed, maybe I shouldn't. Okay, so his muscles were all inflamed, so he had tightness in all his joints. He couldn't move the joints, he couldn't bring his hands to his mouth, he couldn't balance himself, he couldn't raise his leg off the ground. So he required a lot of assistance. He was 68 years old, but he had no health issues. So Tom and I implemented our osteopathic techniques, and within half an hour he was able to bring his hand behind his back. He was able to stand on both feet. He could actually raise the other one. If you position the body, the joints, but most importantly what we're getting to is there's 3 joints that are critical to preparing the body for any manipulation. And that's what we're going to try to explain to you and focus on 3 things. There's 3 joints that the muscles do not influence, nor do they interfere with the joint. They're called stabilizer joints. So they have no motion through the muscle activity. But other muscles that are strained could tighten that joint, affect the joint. So there are 3 joints in our body. Think of us as animals that are stabilizer joints. If you think of a machine, what are the shock absorbers of the joints that the body does? In a car, you can't influence your shock absorbers. You can influence everything else on a computer, but the shock absorbers just react to pressure and movement. So it's written about in Travell. It was written by, I think it was Levitt, who actually stated it in one article. 3 joints that are stabilized are joints that are not affected by muscle activity or opposing muscle activity. Can you guys, does anyone know? Or we'll tell you, but. All right, so Tom, tell them the 3 joints.
AC joint. All right, that's number 1. Influenced by ribs 1, 2, and 3. Sacroiliac joint. And then the fibular joint with the fibula with the tibia, the proximal joint. So those 3.
So the 3 joints that before I start with any athlete or any treatment, I go for those 3 joints because even if they've not been injured, I need those 3 joints back to their position because they control a lot of muscles that can be postural muscles or they can influence the other extremities. The AC joint is critical because it has connections directly to what? The clavicle, which has direct connections to the clavicular sternal joint, which also, if you've been trauma, can affect the 2nd rib and mildly the 3rd rib anteriorly. So the AC joint, which allows you movement of the shoulder, scapula, clavicle, also is influenced by another structure in the neck, your 1st rib. So the 1st rib is like a sensor. It'll stabilize it or release it. So you want to release the 1st rib. It's like taking off the brake or whatever, and then you try to get the AC joint to move. If your AC joint is moving well, it's probably your clavicle is stabilized through the sternoclavicular joint. All the rotator cuff muscles are acting more freely, the supraspinatus subscapularis. You're getting scapular motion, and the shoulder is moving in the upper extremity. So we'll focus on one area at a time. So if the AC joint is critical, it will show you how we look for it and how we'll adjust it. The 1st rib is important to get it in position. That allows me to take out that. I want to stabilize the clavicle. As this AC joint, I put pressure and then I do a manual treatment. What muscle am I really influencing with the AC joint? What attaches posteriorly to the AC joint? The upper trapezial muscle. So let me go back to the upper trapezial muscle. This is going back to muscle anatomy. The upper trapezial muscle is a muscle mass in the neck that divides into 2 muscles. One is the trapezius muscle. So you have a piece of dough that I'm going to split in half, and one of it I'll tell you is the upper trapezius muscle. The other one is what? It has the same nerve innervation.
Sternocleidomastoid.
Sternocleidomastoid.
Yeah.
So your sternocleidomastoid is the same tissue as the upper trapezial muscle. So if you're working on a sternocleidomastoid, it's affecting your trapezius. If your trapezius is tight, it's influencing the tightness of your sternocleidomastoid. They're both innervated by the cranial nerve 11, the spinal accessory nerve. So when does that differentiation occur? At the 20th week of gestation. So in the 20th week, that muscle group now differentiates into the sternocleidomastoid and the upper trapezial muscle. Now, by definition, what is the role of the upper trapezial muscle? Is it a muscle of the back? The answer is no. Technically, functionally, it's the muscle of the upper limb. But a lot of people, when you start thinking the upper trapezius is the muscle of the upper back, and what's the focal point of that muscle? It's like if you have a kite, right? Upper trapezius looks like a kite. So what are the tension points? The tension points are at the top, at the occiput, to the bottom, T12. But where is the tightness coming from? The AC joint. where it attaches in the AC joint. So what I'm trying to bring your attention to is we're all circling around the AC joint. And so there's no muscle that influences the AC joint. And there's no muscle that opposes the AC joint. It's there for you to move it, to get it unlocked, to unglue it, or to derust it, to make it smooth. Once you make it smooth, everything opens up. And then you could do the other work you do. So let me stop there because I just kind of threw a bunch of stuff on you. Do you have any questions of the logic or what I just said to you?
All right. I want to give a shout out. So in the back, I have Dr. Steve Ma. He works with me at ACOM, Alabama College of Osteopathic Medicine. And then there's the Washburns next to him. They're my OPP Anatomy Fellows. And it's Shayna and Ryan Washburn. So, yeah. Thanks for coming. His funeral was last week. No, I'm kidding. He's doing great, actually. What we're going to show you, I mean, I think you'll get a lot out of this today, and I think it's very simple to do. You don't have to worry about which way this vertebrae is rotated or this and that. It's just going to be simple movements to get a diagnosis and see where it's restricted, see what elements are involved, and simple techniques just to put the body back in place. And once the joints are realigned, the muscle strength comes back just like that. It's unbelievable. You can do all the stretching and this and that, but you have to realign the joints. You got a question?
I just wanted to say there's 2 OPP fellows from Nova Southeastern University here as well, me and Tatum.
Oh, hey, I graduated from there.
Yeah.
2000, and I was a fellow also.
So I have a question. Say you have severe degenerative disease in your AC joint. Your ability to free that joint up without any injection into that joint, steroid or antibiotic of some sort, get good results with degenerative disease.
So, okay, so if it's very severe trauma related, you get a lot of calcification for it. You could break up some of it. So if I had more time, I would like to, if I couldn't move it structurally, I wouldn't mind having them get an AC joint injection to free up some of the inflammation, the scar tissue, to help mobilize it. But here's the thing. If I give a shot of cortisone or whatever, whatever new things we find that we're going to be injecting in joints, unless you move it, it's just going to rust up again. That's what I'm trying to say. You have a chance, what you're trying to do is with the injection, and that's what we ask our patients after an SI injection or any type of injection, we allow it the 7 days to have the effect of the corticosteroid or whatever PRP, but it allows me then an opportunity, a window to go in with probably less force to get that joint to move, because it's not going to move on its own.
Yeah, he's worked on me. I have severe arthritis in my AC joints, thanks to a motorcycle accident. So.
I can piggyback on that. We don't, in my office, we don't use corticosteroids. Just a simple lidocaine injection into the joint will make everything relax and allow you to get your mobilization much easier instead of having to put cortisone, wait a week. You can do it right then and there.
So the new people, the new generation of people are going to seminars and doing ultrasound injections, and they're taking, in the old days, like we had to send it off to someone. So, he's correct. But the lidocaine duration of anesthetic is very short. It's a few hours. If you use Marcaine, you'll lengthen it by 3 or 4 times. And you have an opportunity to do it. Now, when you do it with lidocaine, they won't feel it. So after the lidocaine wears off and they've left your office, paid this bill, they go home and they call your office screaming bloody murder. It's okay. I just had one of those calls from LA. They got a shot and they manipulated and he felt wonderful. And then at 4 in the morning, he was going to go to the ER. And the doctor was telling him, no, 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 it's the shot, it just wore off, wait. So what I'm saying is, you're correct. You can do the lidocaine, and then you have the opportunity. You're also correct, you can use a cortisone injection to reduce the inflammation for someone who's fearful or doesn't want to have a lot of pain and have them come back. You could do it then if you don't do the shots. You could ice it. I'm just giving you different things. If a person says, I'm too sensitive, I take an ice pack, and just put it on them, just kind of freeze it up superficially, because the joint is very superficial. I'm using my thumb to use pressure, and then I'm using assisted motion to move the joint. What we're gonna try to show you things, and if you yourself want us to show it on you, we could show how you'll feel it yourself, what it's like, or if you want to work on someone here, then we can guide you with giving you some observations.
You want to demonstrate on someone and then?
I'd like for them to come closer if
Yeah.
they're interested, because you'll see the small things. They're not obvious from across the room, but we could talk about 15-degree angles, and you'll be able to see it. All right, so you want to start? Sure. All right. So just to screen, do you have any shoulder surgeries?
Yes,
Where?
right rotator cuff, the left rotator cuff, and I still have a tear.
Okay, so you just had arthroscopy?
No, well, it
You didn't have a
it
reverse
wasn't-
shoulder
no,
replacement?
No, it
Okay.
was an arthroscopic for holes.
Okay, so right now there's a new procedure that's reverse shoulder replacement. You don't do this because the reverse shoulder replacement takes the whole thing out and there's really no AC joint. So in a simple surgery, she's good at, all right, so you could sit. So when you take the shoulder examination, you don't bring it horizontally, straight in. It's not physiologic for the muscles or the shoulder. So if you took it straight out, you're not to examine it. You move it forward 20 degrees. That's physiologic examination of the shoulder. And then what you do is you can stabilize it against your chest or hold it up, and you ask them to reach down. And her ability to reach down is, 45 degrees, okay? To reach up, she could get to 90. Normal for everyone who's never had a problem should be straight down 90. 90 for everyone. Going back varies. But you should probably get to 120. Baseball pitchers or people are very loose, they can go to 140, 150. Okay? So here she's at 45 and 90. So reach down here. Here she's a little less than the 45, maybe 30. Reach back. And she gets to 90 with struggle. So this one is better outcome. This one is not. Okay. So like I said, there's a couple things we're looking at when we look at this AC joint. We want to make sure that there's no clavicular trauma. That's rare, but sometimes the clavicle will be disrupted from the sternocleidomastoid, from the sternoclavicular joint, and it's going to be really loose. Some people have actually fused it together, so there's nothing there. So, any neck surgeries? Okay. So, one guide to a first rib alignment is you will lose 15 degrees of complete internal rotation. So if you're stuck at 15, your first rib is probably shifted superiorly. The other thing is if you rotate the head, you won't get it to the AC joint. There'll be a 15-degree lack. So her first rib is popped out. But think of the first rib more or less like a turkey. When you put a turkey thing and you cook it, when it's ready, it pops out. Or if you have a car, there's a light that goes on. The first rib is like a safety mechanism to just say, Okay, I'm shifting because I want it to lock it up. I don't want you to go faster. I don't want you to put more pressure. By me going up, I'm changing the pressure of my clavicular joint, which is going to change the pressure of my AC joint, so you're not going to be able to lift 300 pounds. All right. So we have both. Let's see this side. Turn your head this way. And again, she has limited rotation. There are probably other structures, but we're just going to focus first rib, AC joint, clavicle. So, like I said, we're going to do it to everyone that I see. AC joint, clavicle, whether they need it or not, if they have any issue. So, what I found is, okay, how can we do it so I could teach it? Did you ever play with a gun like that in school when you were little and you go bam, bam, bam? Okay, so that's all you have to do. Just put your two fingers, fold the fourth and fifth knuckle down, and your thumb is up, okay? So now this is my gun. I'm going to put my gun close to my clavicle and sternal joint. Wrong hand, okay. Took my finger, so I got my gun. I'm taking my finger on my clavicle and my clavicular sternal joint. I'm taking my knuckle across the ridge here, which is the ridge like where my collar would be here. And now it's just to put pressure. That allows my first rib not to slide up, and it's going to slide down. And the most important thing is my thumb. My thumb is going to slide right into that triangular ridge where your upper trapezius is, and below it is the supraspinatus, where the fatty tissue, where the muscular tissue is, and you'll come right by the AC joint. So finger, finger, knuckle. She's going to look down, and she's going to look to the left, the opposite direction, and down, okay? So this is a technique for anyone. You don't have to be strong, you don't have to be a guy, you don't have to have big arms, big hands, or small hands, because you're going to be doing work with them. You're going to bring the hand, the arm, the elbow bent as close as you can across their body, close to their ear. If you do it far away, you're getting the supraspinatus and they scream. So you're trying to take away the supraspinatus. Now put your head down to the left and down. Take a deep breath. As you exhale, lift it above your head and over. So I'm just trying to guide her. The more she does, the better. Take a deep breath. Breathe out. And sometimes you'll feel it in your thumb. You'll feel a click. I didn't feel any click in her. I'm just trying to make sure that her arm is going back. Here's the limitations. You'll find some people get stuck like this. If they can't raise it over their head, there's another problem. The humerus is shifted anteriorly and superiorly. Like in car accidents, when they're holding onto the steering column or fall, it shifts. You have to get the shoulder gently in. But that's not her case. So look, take a deep breath. Breathe out. There, it's a little click. Take a deep breath. All right, let's look. So was that painful? Tell them how you felt.
No, it wasn't at all painful. I mean, tight because everything's tight. So getting
Yep.
into the position, but there was no pain.
All right, so let's see what we did. So again, we go back to where we were. Reach down. And so her range improved. Reach back up. Got maybe 10 more degrees. Turn your head this way towards me. But her head can go all the way through. So it's just one little session, but again, we haven't even touched this side, which is holding it. So we'll do the other side, just to show you that, you know what? Let's turn the table 90 degrees, because it's hard for me to go back and forth. All right.
Is this like a still technique for first rib?
It pretty much is, because it's basically a range of motion.
First rib.
So we were doing first rib all the time, and we're like, wow, I got the first rib. Guess what happens? It pops right out.
It does. Anytime you go like this.
It goes down, you're all happy, you're all excited to show her. By the time she's scheduling the appointment, it's popping back out. So what we found is if you do the first rib at the sternoclavicular joint, get the AC joint and the first rib, it'll stay. So we'll sit on this edge, that way I can go back and forth. So just to show you where she was before, reach down. Still a little better, but not too much. Okay, so look down, to the right and down. Again, my finger's gonna be sliding over the soft tissue until I get to the bone. My gun with my 2 fingers in the front, and my knuckles going at the first rib. All right, so take a deep breath, breathe out and lift it up behind you. All right, good. Now the other thing is, for some people, you could start, you don't have to start here to arc it. You could start way up here. Take a deep breath, breathe out. Again. Okay, let's see. Now, if they've had a really bad one, I usually try to put pressure on it as I'm bringing it into full motion to break up scar tissue. All right, so look straight. Let's reach down again. Reach back. So her rotator cuff muscles are now working a little better. She's got more range of motion. And let's check this side again. Reach down. Yeah,
That was the wrist, not,
the wrist.
yeah.
So you got wrist problems. All right. But they're tight. So, all right, you guys are osteopaths, so we can just keep going further. So now we have a situation where down she's lacking maybe 10 or 15. She's had surgery, so there's some shortening of the muscle tissue. But she says her problem is she can't go fully back. So when you can't, let's say this is more complex, she had surgery. Let's say you had a car accident with an athlete. So the athlete, a baseball pitcher comes to me, he can't go back, he can't throw. So to give you an example why he can't throw. If you have full motion back, you could throw the ball really well and you have acceleration. If you stop here, what happens is they have to use their upper body more, and if it changes, they throw it to the ground, so they have to change their mechanics. So when I open up the anterior rib heads, I can get the full range and they could perform well. I deal with tennis players, baseball players. Those are the ones that need it the most. So what happens is when they can't turn externally, rotate, the second and the third ribs, which is the pecs, are tender, and she'll be tender there and tender there. Now you could needle this, like if you do Travell's dry needling, this muscle will give you the biggest bruise about the size of a baseball, or at least the size of a golf ball. Even if you do one needle, because the blood supply of that muscle is huge. So I thought one guy had cupping after I did it. I said, did you get a cup? No, that's what you did. That muscle, just don't freak out if you ever dry needle it. And I use 30 gauge needles. All right, so stand up. These are probably not the techniques you use, but so what I do is I take her knuckles, not all the way, relax, just a little bit. I don't want a fist, I just want your knuckles. And I place them across the second, third, and the sternum. But they're in a line, so the knuckles are in a line with the tissue and the ribs. So they're not like this, they're not straight up, they have to align with the ribs. So they're like fitting between the ribs, okay? They're close to the body, your feet together. I bring the feet together because I want to have full control of her body. If her feet are together, she's under my control. If her feet are ever apart, you're going to injure yourself because she'll just resist. But her feet are together. I place my foot behind her. Now I want this arm down because I'm only want to do is one side, uniside, second, third rib heads. Excuse me, I'm going to come around. I'm going to put my hand on top of hers, okay? And then I'm going to put my hand on top of mine. And I position myself, because I'm getting the posterior thoracics that are associated with those ribs, the second, third, fourth thoracics between her scapula. She's going to take a deep breath, relax, lean back on me. All right, do it again. Breathe out. Relax. So it's force. There's no other way to do it. So what happens is when I lean her back, her body's against mine, so she feels comfortable. The reason I don't do my hand here is if you put your hand on her tissue or anyone's tissue, body's in tension. If you place their own hand on it, it's the same energy. They trust it, they release it. But if you put your hand on it first, you won't get it. So use their hand for any procedure that you want to use force, because their body will allow it. The second thing I do, one, because I want them to not to be surprised with the first one. I want to see how they're reacting. The second one, I may do it if I've done them before, but usually on the third one, just they take a deeper breath because they think it's the breathing, which it is. They have to exhale. They can't hold their breath. If they hold their breath, everything tightens up again. So you got to have that full breathing out, then they fully relax. All right, so let's turn.
How much force is your guiding hand versus
In the ribs, a lot of force. And especially the more muscular they are, it's a lot of force. You probably won't do it, but I'm just trying to give you as much as I can. So reach down. Okay, reach back. So we can get more out of it. So what we say to the surgery's fine, it's just that you weren't really reset. And then they notice that they're looser. So in the first rib, what happens, I'll give you scenarios. In the first rib, you could tell patients this and they're like, well, how do you know? Because I had it myself. And the first rib is out, it's painful here, but the most difficult thing is sleep. You tell them, oh, you sleep with your arm up. How do you know? Because that's your body's way of releasing the pressure off the first rib by raising your arm up. Because that's even part of the treatment. You raise your arm up, you put it behind your head as you exhale, putting pressure on the first rib. I could do it myself on my own, the first rib. I can never do my AC joint. So keeping in mind what we said, the ones that do not move by movement of the muscle is the AC joint, the SI joint, and the tibular-fibular joint. And I've had all three. So if you had to do it on yourself, or if a patient wanted to learn somewhat how to do it on their own, I got a glove on. All right, so how I did it on my own, there's two ways. The first way, the most primitive way when I kind of figured something out, was put my head down to the opposite way, take a deep breath, and swing my hand as close as I could as I exhaled. And I heard a click, because for 6 months, this was horrible pain. All right, so that was my first way. My second way was then to put pressure over that first rib and then take a deep breath. But what I wasn't noticing is I was doing pressure, but I was also stabilizing the sternoclavicular joint as well, but that's another way to do it. So let's talk about pain. There's 3 types of referred pain that people will complain about. One is related to your nerves, a dermatome, okay? A dermatome pain is, out of the pain intensity, the most mild. So I never really worry about dermatomes. Athletes will have nerve injuries, they have dermatome, but it's never complaint of pain. Hey doc, I can't feel it. Hey doc, I can't lift my arm. But it's not that they're seeking pain. This more intense pain is from the myotomes, which is the muscles. What's the worst pain? The pain of the bone. So if you have a joint that's rusted, or I call it rusted, but inflamed and off-center, that pain is, if you've ever had a SI joint slip on you, that's pain. I mean, you stop what you're doing. We'll talk about the tib-fib. I had that 6 months ago. Horrible pain. The AC joint, I didn't really have any problems, but I know that it's very painful. People just will do anything, surgery, whatever, shot, to get rid of the AC joint pain. But the AC joint connects with the first rib, connects with the clavicular sternal joint, and also the second, third joints could be affected and hurt to open her up. Now, I'll give you another example. Golfers. I deal with very high-level golfers, pros. And I was going to do a study. When their first rib is out and their upper traps are tight, they have no spatial ability. Their ability to gauge spatial hitting on a putt is off. So if you ever have golfers and you want to do like a little mini experiment, take the ones that have a slight tightness of the upper traps, but the first rib is out, and have them putt. And have them putt, standard putt is 8 foot. You could do 8 or 10 feet. Anything below 8 is not really, takes skill of space. You need 8 feet or more. So do 10 feet, give them 3 putts with their eyes open, and then position the ball and do 3 hits with their eyes closed. And you'll see the spatial awareness go off. You put the first ribs in, release the AC upper trapezius, you have them hit 3 balls, they'll hit a certain distance, you close their eyes, they'll hit the same distance. There's some kind of a spatial awareness from your body's movement to what you're visually processing. All right, so I'll jump to something really different. What muscle in your body has the most connections to your psychotraumatic events of your life, emotions? And if you are working with patients, when you work on this muscle, they will actually cry. Close. So it's somewhere in this area. Have you seen it? Nope, it's not the knife, but he's seen it. Anybody else have seen where you work on a patient in this zone, that they will just cry or have some kind of an autonomic response? The psoas. The psoas muscle is so complex. It's also a predictor of morbidity, mortality, but it's the most deepest psychosocial. So there should be studies done on post-traumatic stress disorder that you should release their psoas. But when you release it's relative. It's painful for those who've had the post-traumatic event. It's not as painful if you never had it. And also it's painful if you take it out of plane instead of knowing where the plane is. Now, okay, because this is a high level, this is not medical school. How many psoas muscles are there potentially in a body? Major, minor. There's 3. There's a minimus. Did you guys know there's a minimus? I didn't know that until about a year ago. There's a psoas minor, major, minor, and a minimus. Now, here's the other thing. What country has the highest incidence of a psoas minor muscle? If we did cadavers, what country, I'll give you a country, it doesn't have to be an ethnic group, but what country is known for having the highest psoas minor in their body in males? 62% of males have this in their body of one country. Japan is wrong. Anybody else? Nope. Nepal? Nope. Bulgaria. But think about what's unique about Bulgaria. Little country, nobody. Weightlifters are the best of Bulgarians. So think about it. The main thing is you lift your body up, you lock your pelvis to get the second thrust. If you had a huge accessory muscle, the psoas minor, comes right up. So what groups have the lowest number of the psoas minor? US. No, US is a collage of people. Japanese and African. Because Have you ever seen a Bulgarian sprinter? If you have too many muscles, but 62% of Bulgarians have a psoas minor, but there's also psoas minimus as well. But I don't know how we got on psoas, post-traumatic stress, because we're doing the AC joint. All right, so who wants us to try it on you, or who wants to try it, and come on up, whatever you want to do. If you want to do it, Tom does this all the time, so he can take some people. We could spend a few minutes just trying it. No, AC joint, AC first rib. So any surgeries? Any surgeries in the
This
shoulder?
is just skin, but, no.
You have any pain? You have any problems that you think you do?
Well, I mean, it hurts.
Okay, sit. Sit here, face this way. Yeah. Any neck surgeries? No? No. Okay. So what we're going to do is I'm going to put you again 20 degrees forward at level, reach down. So you're stuck. Okay? But sometimes if it's just first rib, it's the last 15, but you may be having some more. Pull your arms back. So externally you're not bad, you're about 95. And then just put that over there. All right. Reach down. So this is more of a first rib where you see just the 15 degrees. That one was more like 30-ish. Come back up, and you're stuck at 90. So you're stuck in the second, third ribs here, and you could feel it sometimes. Have you had a car accident?
Well, long time ago.
Long time ago?
20 years ago.
All right, so turn your head. So you're stuck. You're just halfway. Okay, let's go to this side. And this side goes a little further. All right, so we'll just do the basic thing. We'll put your head down. So I'm going to come between here and the joint. It's like basically in the middle. So I'm going to put my thumb right before it. Right there. That's my pistol. My fingers come on top of the clavicle. My other fingers closer to the sternal joint, to the clavicle. I may not get there. And then my two knuckles come behind it just to add as a little support. So you feel those three pressure points? Okay. So, yeah, it's a little lower. Okay. So now, with you, I'm going to show you, instead of coming from down here, which people don't like it because they swing too high, I'll come up here. But you got to come close to the ear. Okay? Put your head down to the left. Take a deep breath. Breathe out. Okay, again. Breathe out. Again. Okay, so when you feel after a few of those, now look how I position my hand. My antecubital fossa is at her elbow. My hand is here. So her arm is more or less with me, and I can guide her with me. When the elbow's tight, it means the elbow is shifted. So sometimes the elbow gets stuck here, then I got to make an adjustment of the carpal and the elbow. But otherwise, go down again. Breathe out. Yeah, your elbows. You have problems with the elbow?
Yes, I do.
Okay. So how you test for the elbow real quick, just you take their palms, they should go flat, horizontal, or past. She does on both. You look at the finger lengths, they're the same. If they're not, they may have had surgery or fractures as a child. Turning in, I'm going to go with the good hand first. You should start to see half your palm. And on this side, she won't be able to do it. Do you see the difference? So the joint here is out of... You guys do elbows? Anybody do a good elbow?
I'm not really shit at extremities.
Huh? Anybody do good elbows? I'm not really good at elbows. Tom is good at elbows. All right, so hold on. All right, well, you have a little bit more going on. All right, so look down to the right. All right, so my fingers. All right, take a deep breath. Breathe out. Now see, stay closer to your ear, because if you're coming out, you're going to affect your supraspinatus. Take a deep breath. Breathe out. Look down. Again. All right. So look straight. So we'll just test our end. I always test for endpoints. Reach down. There you go. Reach back. She's got full range. Let's look at this side. Reach down. She's full range here. Coming back. It's not bad, but she's tight at about 10 degrees. You want this reset? All right. Which side's worse? It's the right.
It's sticking out. Like
It's on the right, yeah. All right, stand up. I've tried to do both at the same time. It doesn't work as well. So, again, so if it's on the right, you're going to take your fingers just like that.
So you're doing now
I'm doing the anterior rib heads.
anterior rib.
And this one's out right
2
here.
and 3?
Yeah, just below the sternal, the second one and the third one. But you could feel it
it's sticking out.
sticking out. Okay. So, again, you know that the ribs are going like this. So I want her hand to go like that. So her knuckles, everything goes in the direction of the muscle.
So this knuckle is on the bone or between the ribs?
I'm going to put so much pressure, to me it doesn't matter because I'm just pushing the whole segment in. My whole purpose of this is that she does it in the same plane, in the same pattern, and I'm going to be pushing all of it down.
Okay.
But her hand is what's going to be felt.
Can you show them activating the shoulder to re-put?
Yeah, you want to do the shoulder?
After this, just
Does he have a shoulder out? Okay. All right, so feet together. Now, I'll show you with the feet together. Your feet together, I'm gonna just play a little. I could move you around, and you're under my control, right? So when your feet are apart, I can't get that. Yeah. So always get their feet together, because then they'll do this, and you're doing something, and you hurt yourself. All right, so feet together. All right, you're gonna lean on me like this. Okay, so take a deep breath, blow out, and then I say relax the elbows. All right, take a deep breath, blow out. That was my microphone being crushed. So let's see how, I mean, if it's been long standing, it may not. Go ahead.
No, it does some.
Yeah. Excellent question. What I'm doing is, I'll pretend there's a person here. So what I'm doing is this. So reach down again and reach back. Now you got full range. So that's released. Huh?
Yeah, it feels better. Where it hurts is back here. Like
Where?
Right.
All right, so you want me to fix that? Feet together. Hold on. When I get set up, I'll get you. All right, so what I do is feet together. I come behind you, I grab your wrists, and even if it's a woman, I say put it in the middle of your chest. All right, now put the other one in the middle of your chest. And now they're together. Now I put my hands over hers. Now I go halfway, I position my body so it's just my pec. All right, take a deep breath. Breathe out. Again. Breathe out. All right, so she didn't move. Now, so here's another way to do it. Take a deep breath. Breathe out. Bend your knee a little. And as she bends, I push because her body weight is coming down and I'm going up.
So you're basically thrusting up.
I'm thrusting up.
And you didn't have to pull
Maybe something that other people don't do, but that's instead of pushing it down, because I've seen so many other people push down and they jam it. But if me coming up and up, I open it up. This one, what we were doing is the fourth one here, because once they get lower, you can't. There's not much movement. You can only get a movement if there's a curvature, convexity up. You can get them in. Once they go down to the fifth, sixth, seventh, then you're trying to shift the thoracic to try to get some motion.
Doc, can you show her?
All right.
He's into the golfing comment she said.
All right. So again, look. You're also Dio? Okay, so this is not how you measure it straight. You go 20 degrees forward, okay? You put it against, stabilize it, reach it down, and he's stuck. Maybe 25 degrees. Reach back, and he's 95. So he's stuck there and there. Reach down. Here he's not bad. So in here, he's not bad. So when you sleep, you gotta sleep with this arm up. I know, but what I'm saying is if people freak out when you start telling them, like, you can't sleep on that arm, or you can't do this. It gives them confirmation that you know what the problem is. That's all it does. It's like, how'd you know? I said, this relates to this. And then they get more confidence in you. Turn your head. So his head, he could turn almost there. It's not bad. Here he won't be able to. So here he's lacking. So normally people would start saying, let's adjust the neck, adjust the neck. No, wait for the neck. The neck is, and there's a way to adjust the neck too. So what we're going to do is, you're going to feel the upper traps here. You see it between my fingers? And they'll come down to, now you know when you get all this hairy patches stuff? Like here. So this indicates like his last phase of development. When you have a hairy patch, it's called spina bifida occulta. So there's a weakness in him here. So if you ever had to adjust him at T2 in that area, he won't adjust because he's got a spina bifida, that hairy. When it's really big and open, it'd have so he's going to have stuck here, and what you'll feel is he steps over it and he dives and goes up. But here he's going to be stuck right across here. So let me look at your back. So in his back, you can see here, that's going to be an area that's going to be hard to adjust right there. But as long as you know what you're working with, you don't try to keep adjusting. If you see that or that, you're not going to get much. You do 100 different things, you're not going to get much there because structural this changes.
I did adjustment of my knees, and now I had a knee problem. I still do, it's a little bit loose. And when I was doing, I think, Zumba, it would just hurt, especially going upstairs. So and one day I was basically like this. Actually, it's a patella. And I heard terrible click, but I don't have problems.
No, what happens is on this part right here, laterally, is the tibiofibular joint. If that's out anywhere, that's painful as heck. So when your patella is slid, you're able to slide the fibular joint and the tibiofibular, and it reset. I'll check it for you.
Yeah, that was good.
All right, so do you want to do it? Oh, you want his wife to? All right, so show me what you would do.
Well, I don't know, that's what I was watching.
Okay. So come from this. So here, sit over here. Sit here. Sit here. Sit here. Yeah, sit like this. All right. So the last thing we're going to worry about is the first rib. So what you're going to do is you're going to make your fingers. You're going to put the first two there. You're going to put your thumb, across to. Maybe you'll shift it the next time. You'll put it where you feel it. When you start moving it, maybe you'll shift it a little further. But it's right where you're coming to the bone edge. And then these you just bend and don't worry about it. All you have to do is just place them. You place it and that's it. But the main thing is you hold this and you hold that, and then he's going to do all the motions. He's going to look down.
So you were here in the groove with this figure?
I'm on the clavicle.
But this one is in the groove?
No, it's on the clavicle.
On the clavicle?
Yeah, they're
And
both
this-
on the clavicle.
Oh, like, oh, okay, both on the
Yeah, so if you have short hands, you may be here, you may be here. If you have really long hands,
So,
you
but
can
they
go-
are both on the
but they're both on the clavicle. Because the clavicle and the AC will shift, and the first rib will slide down. Right. So look down and to the left. Now we're going to raise this. Okay. It's tight. Okay. So now when you do it, when you try to get them tight, when you come this way, you'll reposition your thumb maybe a little bit. All right. So take a deep breath. Breathe out and bring it behind you. Nope, just behind you. You don't have to twirl it around. Take a deep breath. Breathe out. It's basically fold it over. I don't want you to do this because you're going to get all sorts of muscle grips. I just want you to fold it over. But if he doesn't fold, his elbow's a problem. If he folds over easily, his elbow is not a problem. It's just a quick check. Take a deep breath again. Breathe out.
Yeah.
All right.
You got to fix that on me for this.
All right, so now we'll just check him again. Reach down. You can go as far as he wants. Reach back. And now his elbow just.
Yeah, that was actually amazing. The range of motion changed in that one little thing.
All right, yeah, I got to do the SI and the tib fib. All right. So. All right. Just due to time restraints, okay? We're going to attack a small joint right now because the SI is the most complex. What? What, the SI? Let me do the tib fib because it'll take me about 10 minutes. And then we'll spend the rest on the SI.
The SI, you're all going to be amazed with the SI. It's just incredible.
Well, because it's so complex. All right. So I'll give you. So if you hear stories, you'll remember things better. So I played soccer semi-pro all through my youth because it was a Ukrainian thing. I was Ukrainian immigrant family, and every kid had to play soccer. But now you're Greek. Now I'm Greek. So what happens is in soccer, you get hit in the legs a lot. And I never realized it, but I had such bad shin splints, and I thought it was shin splints. Now I recognize it's a tib fib joint, which it did affect your shin splints. It's a joint that no one really talks about. There's a real joint tib fib, and in the last 6 months I had it. And I'll tell you from my own experience, which is not written in the books. Getting a little echo. Oh, okay. So I'll give you my personal experience. It's not written in the book. I tried to kick off my covers, which my wife placed really tight, and I tried to kick them off, and I felt something shift. So I felt, oh, it's a little sore. Throughout the night, I would wake up, and it would be burning. It would hurt. I would get a shin splint pain down the leg, and you get pain across the back. It's just right over the ilium. It's just a real nagging pain. I had to get out of bed and move around. And so I repositioned it because I could reposition it, and I was fine. I wake up an hour later, same thing. Pain here, going down the leg, shin splint. So I'm moving my leg in different positions. But I want to tell you one thing. No one talks about it, but there's this really bad pain here. And my car accident patients talk about it because they have their foot on the brake. They get hit from behind, and guess what happens? We never look at the tib fib joint, but they have that pain coming across that back. And you go, oh, quadratus lumborum, oh, iliolumbar ligament, oh, we'll get an MRI. Oh, it's spondylolisthesis. It's not. There could be the tib fib joint. So who had a tib fib joint? There's a lady here. She left. Okay. All right, so dancers get tib fib joints because they're moving against resistance, rotating the legs. So where is the fib tib joint? You can lay down on your back. The tib fib joint is located from the lateral side. So it's, you know it's on the lateral side because it involves the fibula and the tibia, and there's a joint there. And that joint is a rotational joint, but it also allows the patella to glide up and down. So some people report, oh, when I did a certain movement, my patella shifted, I heard a pop, and I was fine. What they did is not the patella, they got the tib-fib joint in place. So, bend your knee. So, men and women probably turn the same through the knee. You bend the knee to take out the hip. You turn the foot in, and you turn the foot out. So internally, anything internally, let's see, I forgot my range of motion. So internally, she go, what's the degrees, Tom? 15 in, so she should get 15 in and 30 out. When they have a tib-fib joint, they only go about 5 to 10, and they come here about 5. And if the ankle, you could also check the ankle because it could be in the subtalar joint of the ankle. But the tib-fib joint, the easiest way to gauge it is if, and now she doesn't have that movement. Now she's stuck, okay? You can't move it anymore, can you? Outward? Okay, so let's look at this side. Turn this one out. So do you see how that one moves out? So this one, move it out. It doesn't move. So she just shifted her tib-fib joint out of place. That's, again, the 3 joints we're talking about, AC, SI, tib-fib, are not influenced by muscle movement or opposing muscle movement. Other muscles that are tight can affect it, but they won't do it. So she's stuck. So what's interesting with collaboration is that we're teaching you stuff, but then the next year we want you to explain to us what you find. So in collaboration with Tom, we decided to take a trip and just work on collaborating our ideas. And Tom says, I want to show you my $1 million move. I go, really? You got a $1 million move? It was the tib-fib joint. So Tom, show him the tib-fib joint move. So also what we're going to show you is there's different ways to skin a cat. He does it sitting. I'm going to do it laying, okay? So you develop your own style, but what we're identifying you is 3 problems. So Tom, speak, go ahead, tell her what you're doing.
Turn this back on. So what I want to, is that on?
All right. All right, so what I want to do is just grab here also where the femur and the tibia meet together, and that will also affect where the fibula and the tibia meet. So I'm just going to grab around where the tibial tuberosity is, and I'm going to motion test and see which way the leg likes to go. Comes in a little bit easier internal than external. So what I'm going to do, I want to push it out externally, so this top hand will rest on the medial aspect of the tibial tuberosity here. This will come up underneath. So I'm going to push with this hand and pull with this one, basically. So all I'm going to do is just hold it and start to turn it in, out, well, external rotation, just like that. And I'm going to hold the tension here, and all you have to do is relax. Breathe in and out, and relax your leg. So I'm just putting an external rotation on this right here, and that will help move this tib-fib joint over here. That's it. Let your leg totally relax. There we go. And what you're going to do is you're going to kind of feel it move and drop down a little bit as you're doing this. So it's just the constant tension on this. Holding. There we go. Breathe in. Breathe out. There we go. I don't know if you feel that movement. It's just...
Are you monitoring your tib-fib joint?
Nope, just my thumbs right here, but I'm feeling back here and here, just the gastrocnemius. But you're going to feel where my thumbs are, you're going to feel it. And what it's going to feel, I'm going to exaggerate it, but it's going to feel like it does that and drops, just like that. And if you go the other way, it will come in and drop. That's what we're looking for, just that. So I'm pushing with this top thumb and pulling with this bottom one, just like that. And again, the patient has to kind of relax, breathe in, Breathe out. And it might take a while. Oops, that my thumb slipped.
Would you do it the other way for restriction is with intimate rotation?
Exactly. So you're just engaging the barrier. There we go.
Is this something you would do if you had like a fibular head lesion, somebody had foot drop?
Yeah, I would do that. Anything that will take pressure off back over here. So it could be this is restricted motion, pulling tension here. That's one thing I learned all over the years. You can have something going on here, here, in your back, something that's pulling tension on any of these muscles. So wherever there's a restriction, I want to just try to free that up. Now we can.
All right, so lay down. So the one thing I always do is double check my work before. So we'll double check. So turn your foot out. So she's got more, okay? So I used to do a butcher man's version. Tom brought the idea how it's done. What Tom was doing was he was manipulating the fibula, putting pressure, but he was retracting it down and rotating it.
Yeah, you could do that.
So I thought, okay, how can I do it quickly? So at first, I'm just going you through so you could explore. So the first, when I was doing it myself, I would grab my leg, and with my arms, so I would tell my patient, with your arms, just put it right over your fib, or over your fibula and over your tibia, and just turn your foot in, rotate it in, and rotate it out. And as I did it myself, I would do this to try to, in bed, to try to reset it. And it would reset a little bit, but it wouldn't hold. So if you're in a bind, you just, bend your knee and then just rotate it with your foot motion in and out, in and out. The problem lies, it didn't work as well. Why not? Because what Tom showed you is I gotta slide the fibula down. If it's still riding up, it's just sliding back and forth. So I gotta drive it down. So my next step was, my therapist helped me, that was the best way, is he would hold the fibular head and I would take the subtalar ankle heel, Tom, just hold the head here at the fibular head, and then as I pull down, try to reset it. So what I'm doing is I get her moving so she, just to distract so she's relaxed, and I'm putting my force of my fingers on her fibula to try to take my fingers and bring down the fibular distal attachment downward. So I'm bringing the force down as he's doing that. Take a deep breath, ma'am. Breathe out. Okay, so now, just to double check our work, turn your leg out, and there it goes. But this way, if I pull it and pull it, if you have a therapist or someone who can help you, if they could push down on that fibular head as I'm and then push it towards it, I could slide holding the distal fibula, and then it'll just slide right in. So what Tom was doing was using your body weight. By sitting down, he takes out your hamstrings, so you're not guarding it. And he's pulling you down while he's rotating. But being a butcher I am, and I have to see patients really fast, I just get my therapist, put it there, bam, you're gone. I don't have to.
But that's not a one-man patient.
We'll figure it out one day how to do the one man. We'll put weights on her leg. Okay, there's a product on TV. And I thought, how stupid is this? They said, oh, we can cure all back pain. Did you ever see that one? Come on, you guys don't watch late night shows or anything? So it's a strap. You got all these older people who, oh, I could play pickleball now. I could walk with my dog. So it's a strap. And the strap is with like something like a little square putting pressure on it. So it takes away all back pain. And for the time, I thought it was the biggest crock. I didn't buy it yet. But now, since I had the back pain, and I'm telling you, when a patient complains of this diffuse pain across that ilium, I've done 35 years injecting it, dry needling it, manipulating it, putting braces, everything. At tib-fib joint, somehow connects to that. So this item, by putting pressure on that tib fib area, keeps it in. And the back pain goes away.
What's great with ankle springs too,
The,
Do you think it's fascial from the biceps up to the hamstring into the sacrotuberous SI?
the answer is no. Because it goes back on what we started our discussion is there's no muscle that can affect it. But it's in the fibular head, but it's not in the joint. So the muscles there are muscles that can affect it, but it would have, that your biceps femoris and your hamstrings, they're used all the time. But it's that joint. Remember, these joints manifest themselves most with weight bearing, either with standing or resisted weights. But that's, all right, so we don't want to bother you. Here, lay down. So I want to show you just some things not to do.
On my back?
Yeah. Just lay down. Well, you're the closest one to me. Don't stand so close. All right, so when you do tib fib, don't judge movement this way in a lying position, because that's affected by the ankle, the tib fib, the femoral, and the SI. So this will not yield. You could have stuck here. You say, oh, it's your tib fib. No. You have to take all the other components out and move it. But you still haven't taken the ankle out. So if you wanted to take the ankle out, just put your hands on both sides of the subtalar joints. She's fine. And then you kind of pull the calcaneus off the talus. If you can pop the calcaneus off the talus, then the whole myofascial train is released for you. All right, so are you comfortable? No. You want a pillow?
No, I'm good.
All right, well, so SI. SI is the most complex joint. Why? Because in most people it's a little different. It's irregular. It's not a joint. The joint itself is the size of a what? What kind of, if you put a size to it, what kind of a coin is it? For the SI joint, because it's a joint, so it has to have a joint, but the whole SI is irregular. But the size of the joint it's like a quarter. No larger than a quarter. So it's no larger than a quarter, but it's irregular. The only thing that is predictable in its movement is that it could shift forward or sagittally, okay, and that's reported by studies. So the only thing that we know that it could shift is forward and laterally. We're not shifting it side to side or any rotation. So SI joint, but it's so complex. So how do we, so how do I assess for SI joint? If a SI joint is shifted on one side, it'll lead to a dissymmetry of leg lengths. It's a functional leg length. So when someone says, oh, you have a leg length disorder, oh, no, I don't, how can that be? No, it's a functional leg length disorder. Once you align it, it goes back to normal. So you grab, you look at their shoes, and she's fine here. Her heels match. Her ankle, her malleoli are similar, okay? So assessing the SI joint, let's say if the ankles and knees are fine, sometimes you could, well, forget that. So the SI joint assessment. Bring your knee up. So now I took out the ankle and I took out the tib fib joint. Now I just have the femoral, and now I have the SI joint. So now turn your foot in. No, turn it all the way and touch up there. Okay, so on everyone, when you're young, an adult, young adult, you have no problem touching almost the ASIS, okay? So she's stuck just above her knee. So her SI is out of position. That's all I could tell you. Now, that's in one plane. Now, coming outside, she only goes 15 degrees, 20 degrees. All right. Are men and women the same degrees? No. Why? The angle of the pelvis. That's how we determine whether the cadaver is a male or female. We look at the pelvis. The male's pelvis is round in the center, the women's is an oval. And that affects the angle of our femoral. And that's called what? The Q angle. So the Q angle is larger in a woman. It's 15 to 20 degrees, and in men it's like 10 to 12 degrees. So what happens is if I take the pelvis out, and I should be able, I can't go any more in. So men and women will go to 90. From here, they'll go to 90. But coming out, men will go to 60. Women can go to 80 or more. That should be normal. But for her, she's stuck at 10 or 15.
How do you differentiate pathology versus SI?
Hold lecture. So, but how do I do it? I eliminate the SI. Then I figure.
Okay.
But but it's a really good question, because if you get the SI in, but you don't get the femoral head in, you ain't getting nothing. And the femoral head out hurts just as much. So let's bend your knee here, turn your foot in. So you see, here she's fine. So we have one side that's really out, and this side is fine. Come out. And here she's not that bad. I mean, she's at 60. It's not perfect. So there's many ways you can do the SI alignments, right? What the common ones the chiropractors do is what? Worst thing in the world. Because I'll explain to you why. What are they actually doing? They're pushing the sacrum, jamming the sacrum, hoping it will splay out the SI joints. But if a person's been in trauma, that's the worst thing you could do. It's like having a repeat car accident again. So I always tell them, never do a drop table. If you can't figure it out, it's easy to do. So one technique is, all right, we'll start with your technique. So, okay, can you roll on your stomach? All right. So we'll do your technique first. So how would you do a sacral alignment with compression?
Well, it's flexed, extended.
We don't care. I'm telling you, we have a problem on the right SI. I want you to fix it. Student, come over here. That's what we do. So the first thing I'm going to do is I'm going to double check my work, okay? So when she's laying on her stomach, she should come to neutral this way, and she doesn't, okay? And here she should go at least 60 degrees in, and she does. She goes 80, which is, women could go more internally in is because of the femoral alignment. So here she's stuck a little bit, and here she can't, here she's okay. So the right one is the one that's stuck. So this is a double test. So now I'm saying we got an SI. So do you do it, or do you want me to tell you what I want you to do? Okay. So what Tom and I have been working on, we're doing a study at his school, is that the ilium are the two large bones. They're like the scapulas, right? So all you have is a sacral, and you got the SI near there. So what you want to do is, she's got good pants, so we have a seam in the middle. So I want to be as close to that seam as possible, and I want to use my hands. I want to use my hypothenar muscles on the convexity of this thing, because the SI joint is right at the convexity of it. So I'm taking my theners, and I'm placing them this way, and now she has to turn her head one way or the other. I don't care which way. Either way it works so far. So turn your head one way, but they can't hold it straight because it won't compress. And then, so what we do is, as she takes a breath, we just put pressure down on trying to reduce this down symmetrically. And then it should align itself.
So basically an anterior, inferior force.
Right. So now, that's one thing you could do by yourself. Now, to make it even better, if you had an assistant, so Tom, you want to do it? So with the assistant, guess what we do? I take her malleoli, and I distract it a little bit. Take a deep breath. Breathe out. And what happens is once it goes in, it unlocks my malleoli. And sometimes they'll hear a click and she'll move. Remember what I was trying to show you, this movement? If it was just one move, so basically I could test the student if you're a teacher. You say, all right, show me your test. And do it again, Tom. Take a deep breath. Blow it out so we could hear it. All right, so let's see if Tom did. I didn't really feel it, but a younger person could feel it. So the test is, can she get flat? And she got flat. Okay? I passed. So I'm just saying is, if you're an instructor, with my therapist, I can get them in and out of my office. I don't have to do drop table. I don't have to rotate. I don't have to get myself over their body. I don't have to make contortions. I just go in, midline, turn, take a deep breath, and you can't harm them. Because think of a drop table, how much you're dropping them 4 inches with their weight. This is nothing.
And it doesn't matter the diagnosis of the syndrome?
Most of us walking around, half of you are going to have SI problems, SI subluxation.
And you grab above the malleolus?
I grab the malleolus and I move my hands, and I'll feel a click, click, click. And it's just because I have a therapist who I work together, and then it's just so much easier to have a retraction and bam. All right, so lay on your back. So that's one way of doing it. I'll show you another way of doing it. All right, so straighten out your feet. So again, I always check leg lengths. They're actually, now they're different. So one is longer. So something may have shifted, but now she has another problem. So I can go flat. And here, I can go pretty much flat. She's a little tight on this side. So bend your knee. This is the one we went this far. Turn your leg in. And turn it out like a young lady. And then what I do is after I get them all in, this is just habit, I grab their malleolus, I grab their calcaneus. If you could release the calcaneus off the talus, you're home. Yeah, you just...
I thought you said abracadabra.
No. See, this one she's jammed in, so there's many other structures that are a problem for her. So the other way to do, well, let me see, hold on a second. So what I do now is I turn her leg out and I look at her hip to see if the femoral. All right, so Tom, I need you to push through here. So, all right, so in car accidents, the hip goes superiorly and anteriorly slightly, but they'll complain of groin pain. Okay, so this is what it is. So what happens is we put a lot of trial and error. So the first thing that's going to hold you is the psoas. It also has the post-traumatic stress in it, so it's wanting to hold it, doesn't want to move it. So what I had to do is figure out what is the angle of the psoas. So I take it 15 degrees out, no more than 15, because once I take it out, the psoas is stretching. So I take it out 15 degrees, and I turn the leg in to bring my femur closer so my psoas isn't tight. So I bring it out 15 degrees, turn my foot in, I grab the malleolus and the heel under here. Take a deep breath for me, and breathe out. And then Tom, go. Again, take a deep breath. 1, 2, 3, go. All right. So let's look at her feet now. So now I know whatever abnormality she had, it's now symmetrical. So now I do my checkpoints. Always do your checkpoints. Does the leg go flat? Yes. Does the leg go in? Yes. Bend your knee. Does it go in? Perfect. Does it come out? More than it did previously. So she's reset.
Ready for the miracle.
Let's go for the next one. That's one way, sacral. Let's do another person who has another hip problem. All right, so I need you to... You don't want to be on TV with thousands of, hundreds of people and tell them about your problems? No? Okay.
I do geriatrics, and 80% of low back pain comes from the sacroiliac.
Yes, that's the bread and butter of chiropractic.
And that's what I found out.
All right, so lay on your back. All right, so the first thing again, leg lengths. Quick. Leg lengths are okay. Feet flat. So this one may go down. This one's not going down at all. Turn it in. And women will go down further than men. It's not too bad. So her only issue, she's a little tight, 5 degrees there, but here she's stuck about 15, 20 degrees. Bend your knee. Turn your leg in. It's not too bad. You're pretty close. Turn it out. Yeah, you're stuck. All right. Bend this one. Turn it in. It's not bad. And you're stuck here. All right, so the chiropractors, what I find is their technique is roll on your side. And it works a little bit, but it just locks them up by the time they get to their car. So you drop the leg, you put the hand on the hip, you turn their head, you take a deep breath, and you put your forearm in your antecubital fossa, and you just kind of try to click it in or push it towards this way. Try to slide it forward. So go on the other side. So that's what I think chiropractors do. But again, it's hard because you have to get over it. Sometimes they're huge people. Sometimes the women don't want you to come across, or, where do you support them? Their shoulder hurts, their pec hurts. That's the technique, okay? So we don't do that. Okay. So let's see. Yeah, you're still stuck. All right, so technique number 2. Let's say you don't want, the sacral is hard or they're very obese, or the way to do it is pulling. Pull and with the breathing, okay? So there's 3 planes you do it. You don't do it straight on. I take it always about 15, everything is 15 degrees. 15 degrees in the arms, 15 degrees in the foot, 15 degrees out, 15 degrees in the shoulder. All right, so I grab the malleoli. I have my bottom 2 fingers, which is to support the heel to get the talus off the calcaneus. Take a deep breath and breathe out. There, it clicked. All right, so let's look what 1 click does. Now, I'll do it in this plane, and then I'll come out, and I'll do it in that plane, and I'll come in, and I'll do it in that plane. But we just did sort of the first one. Bend your knee. Turn your leg in. Turn it out. That's all it took.
So are you plantar flexing at the same time?
Where?
On the foot?
No, my goal is, I don't care what I do in the forefoot. My goal is to take, you see the sock?
Yeah.
That's what I want. That gray area of the sock, I want it to separate.
It's your on traction.
I use traction, so I put my fingers there to try to have it move, and it moves.
What he's doing there is to distract her by wobbling back and forth, so it relaxes her and then eases quickly.
So when I initially do, what you're seeing me do initially is I'm just seeing if she's tight guarding me. So what I do is I do this. All right, just relax. And then what I'll tell her is, before I do it, I say, now take your big toe on that one and wiggle it, and they'll wiggle it, and then it just, boom, it comes right out. But I just want to see how she's going to respond mentally or her body to me. And now you can feel her talus moving all over the place. So this one is fine. And again, you check your endpoints. If you didn't get it from that, go to a different technique. But it takes you like 30, 40 seconds to get them out of there. Turn your foot out. Turn your foot in. You have a little bit, but do you have any problems there or no? Tom? So what Tom is doing is, we don't go right over it because there's too much bone and capsule. You come to the side of it, and you use your palm of your hand, and all you're doing is just, as the person's pushing, you're just pushing down at 45 and into it, and they'll slide back in. All right, Tom, ready? Take a deep breath. And I'm holding the malleoli and a little bit of calcaneus. Breathe. Pull. There. And that double clicked again.
There and there and there.
We heard it.
Right, but what I'm saying is, I'm just showing you how you could release everything. And it's just knowing what to do and then going back to your endpoints.
It is helpful when you have an assistant like that. I know you have to do it yourself sometimes, but that is great.
You could train anyone. You don't need to be a medical. Just just tell them what you want to do. I like to do this because I could feel the subtalar, the calcaneus talus. I feel that's where the motion is. If he's not doing this right, it doesn't matter because I'm pulling it. All I want him to do is just stabilize it and pushing it towards with me. So he doesn't have to be exact, like doing this or this. All I want is someone to go the lateral half of the leg in the direction of this, so a slight 15-degree angle. And all I want to do is, when I do it, just to put pressure and push it down, because I'm going to slide it in. All right, so now, who else has an SI? Okay. You're okay? No? No, my joke is this. This one's for free. This one's $1,000. All right, so Tom, I think you paid it with the conference fee. All right, take a deep breath. Breathe out. There it is. All right. Yeah, because you felt it, right? All right. Yeah. Okay, so I'll show you what athletes do. How old are you?
41.
Lay down. You look like the youngest one here. All right, lay down. All right, bend your knee. Turn it in. Yeah. See, you're not that bad. Turn your foot in. All right, so I did a lot of NFL players, and I did a lot of young first rounders. So get up here. So I would freak them out. Hold on, before I do that, I got to check myself because I screwed up one time. So I'll show you how I align myself. So this, I can do this. Here, I got no movement, okay? This is not bad. I don't even go to neutral. You guys could test. You see it? Okay. All right. Here, just make sure. So how do I put myself in? You ain't touching me, okay. So you grab above at the malleoli. You don't grab the foot. You grab the malleoli or higher. You stabilize the knee over the joint, so it's straight up 90 degrees. Take a deep breath. It's force, all the force I can put by stabilizing this and jerking it while I exhale. Your patients don't want to do this, but.
When you don't have somebody around to help you, you gotta figure out how to do it on your own.
Yeah.
Holy shit. Whoa, you're gonna go dancing tonight.
All right. Now watch this. So, you got your shoes off? I'll take my shoes off.
Pretty good.
All right. So stand me. We're going to just push, not jerk, just push. Put your shoulders on mine wherever you want.
My shoulders?
My shoulders. Put your hands on my shoulders,
Okay.
wherever you want.
Like, we're going to be kissing.
Trust me. You're going to come towards me, but I'm going to push you away.
All right.
So are you comfortable there? Because I'm going to have to put mine on you.
Okay.
You're good there? All right, so, okay, get in position.
All right.
All right, so now start pushing me towards me. Go ahead. Oh, wait, my shoulder. Don't spray them out. Just go forward. Go. Push.
Yep, I can already feel you got leverage. Yeah.
Well, forget it. I'll change my leverage. Okay, just get in your position. You have an excuse already.
No, I can feel you. You're pushing.
All right, I won't
I got
touch
nothing.
you. All right, go.
Yeah.
Whenever you're ready. You could do it to, who's the, Miss Dr. Ma, come over here. You look young. You want to take your shoes off because they may slide for you. I didn't check you. I didn't check one guy and he threw me against the wall. Let me check you before I do this. Right. Lay on your back. So if your SI is out, you have no strength in your quads or hamstrings because it won't fire maximally. Bend your knee. Turn your, that's good. Good for me. You got problems with your knee. All right, stand up. You're perfect. Come over here. How old are you?
38.
38? All right. You work out?
Not at all.
Oh, good. Put your hands on me. All right, all right, go. Push. Whenever you're ready. Just go ahead. So I could just take them anywhere I want to. I'm 65, and I don't work out at all. Never. I mean, never.
It's true.
But you will not fire. You'll only be 80 to 70% of firing. Lay down on your back. I'll show you now.
Do you teach this technique to your offensive linemen?
They used to fly me into University of Tennessee I was preparing guys for NFL combines. I was at FIU. I went to UF with the coaches. I know some of the coaches personally, but I stopped doing that. But
Wrestlers as well.
yeah, actually, I wrote in the book of Encyclopedia of Sports on injuries and kinesiology. I have 2 chapters with a publication by Sage. The next month, I'm going to Golden Gloves, the guy who runs Golden Gloves, and work with his teams in Miami. But I'm this Athletic Florida Association. I've done like 100 fights, MMA, karate, UFC. If you see the guy with the white hair at UFC, I've done 5 in Florida. So raise your leg up. So I show him this. Raise your leg all the way up.
I'm trying.
So that's his hamstrings tightness because of the SI joint. So watch what happens. I show my players. Now stand up. You're going to be an offensive line. It can't push you. But watch this. I'll take one finger. Ready? I'm going to push you down. Ready? Hold me up. There's no strength. This one? No strength.
Same thing you ever do the one with the hands out?
That's a different thing.
But when you're off level, the one hand goes just flops down.
No, there's a whole energy thing on that.
Yeah, is that like when the leg left in scripts?
No, this is mechanical.
Okay.
There's a whole energy thing I could show you. It'll freak you out. It's like colors, patterns, touching. There's a whole energy concept. Like if you ever watch players, if you're playing against a team that has non-primary colors, they'll lose. They have weaker, because it weakens them by the eyesight of the pastel color. All right, so let me fix him first. So lay down. So lift your leg up, all the way up. So that's it?
That's it. Tight.
All right, no you're not. So they say they're tight, they're not. Hold it there. Don't let me push. There's nothing there. Lift that one up. All as far, yes. All the higher. And I'm pushing and that's about it. Okay, hold your leg up. Don't let me push down. All right, so turn around, have your feet this way. Turn around. Tom, let's see. Let's just see what we're going to do. Turn your leg out. That's not bad. Turn this one out. You can't. You lack about 10 degrees. Not too bad. This one's not lacking. Turn it in. All right. I just want to see where he's at. He's tight there. Turn your foot in. Other way. This tip fib's okay. Bend this one. Turn it in. Turn it out. Yeah, you're stuck here too. Do you have any pain here? Yeah, okay. So if he's messed up here, what I'll do is this. I'll just start it with him real quick. Do the subtalar joint, try to open it up before I do the SI. There. I'm going to do the tib fib. I'm going to loosen it up first. Now, here's the thing. The fibula will move. The tibia, does it rotate? Can someone tell me it rotates? How many degrees? 7 to 12. So it does rotate, but most people don't think it moves. So Tom, so here's what I do. If I have, no, here. What I do sometimes is I'll use my thigh to support them here. Yeah, just got, I need the tib fib. That's, okay. Got it?
Yeah, I felt that one.
Let's do this one too, just as a precaution. All right. So which technique do you want us to try? Sacral or just pulling? Let's do the sacral. Lay on your stomach. All right, so end points. First thing I'll check. Not too bad. This one's not a little tight. This one's better compared to this one. And then this one. Sometimes if they rotate out, their glutes are involved.
So you should be laying flat with the head facing one way or another.
When I do that technique, yeah. When he's, yeah, because it's stuck there too. All right, so Tom's gonna take a deep breath. Breathe out. Okay, the right one, this one released. Okay, turn it up. All right, flip over again. I want to check your femoral heads again. Turn your foot out. See, his femoral head on this side is off. On this side. All right, so Tom, do this side. Yeah. Okay, take a deep breath. 1, 2, 3, push. Okay. Let's bend. All right, turn your foot in now. Turn it out. So here's another thing. If you ever have an athlete or even an older person, for men, if you take the men and you put their foot in, here's what I could tell him. He was one of the fastest kids in his class. Were you one of the fastest kids in your class? Why? Because I've had the top speeder. We had a silver medalist come, and I found it by observing it. Everything you could observe. You're the slowest.
I was.
With or without the braces on your They made a movie on you, didn't they? All right, so. Okay, well, let me get me someone else. I'll tell you in a second, but I want to
understand the anterior head, femoral head. How do you test that?
What happens is when I move your leg, watch, I'm looking for this pocket, okay? This pocket here. As I turn it in, it glides. But sometimes it'll hike up on you like that. Okay. When it hikes up, this femoral head is moving more. Okay. So when it glides, there should not be much movement of the clothing. Okay. And this one, now it's better, but before it was pulling up. You saw it, yeah. All right, so bend your knee. All right. Bend this one. So the reason it's not the SIs. The SIs are in. Now you'll crack them like this. Adhesions in the knee will break up because their knee hasn't moved. When you hear those snaps, those are good. They say, "What's that?" I said, "That's the adhesions, the glue that was stuck in there," and it opens it up.
So you got to pit him against Dr. Ball now?
No. Okay, lift your leg straight up. So you can get to 90 or close to 90. And this one. So how many hamstring stretches did we do? Nothing. It's all structural. You didn't do one damn hamstring. Just lift up your legs, hold it up, hold it up. Here, push him down with one hand. No stretch. You can't. You want to try it? Push this one down. Hold it up. No, let him try. Before, you saw me with 2 fingers? Boom, boom. So you change everything. Now, when you do S side, the first thing you got to caution them as you get up, you're going to be a little dizzy. Why? Because the psoas and everything else resets. There's a whole sensor system that bases your pelvis symmetry, and I just changed everything around.
When you tell them to get up, you tell them to roll on their side and push up rather than lurch forward?
No, I usually help them up. I just say you're going to get a little dizzy for a few seconds when you get up, so don't try to jump off the table. So you can come back up, and I just pull their legs up. And I say, just wait there a second. So I don't, by standing mean holding them, they reset, and I said, you can go. Let me check Dr. Ma to see if he was quick or not. Lay on your back, Dr. Ma. So what happens is, men, if they turn 60 degrees, 45 or so is at least normal, but if they can get 60, they're not. But if they can get to 70, and the other thing is, if they normally would have a narrower base, so it's more rounded, not wide, not like Dr. Tom. We tease each other. But more rounded, and they could turn in, they're fast. I mean, their speeds could be like, they're fast sprinters. They're not long distance, but they're fast sprinters. And a lot of that is because the psoas can really fire. Your psoas will fire very fast in that alignment. The pelvis is more rounded. It's not like wide. It's more of a rounded pelvis. So him, I don't think he was fast. Were you fast?
I never really ran the table.
Didn't even try.
Got a scholarship for it.
For what? All right, let me, so we're kind of done. If you want to go, if you want to stay, we'll stay a few minutes. I think this gentleman wanted us to look at his sake.
Can you show us the psoas release you're talking about? Yeah, I've got bad psoas too.
That's fine. Psoas release is tough. I'll show you what I do. Okay, so. Okay. What's that?
He wants me to learn so I can do it on him.
Okay, so if I do a psoas release, it's good for 8 months. Okay, I'm just telling you, because if you get it isolated properly, you stretch it out, it'll fire fine. It's like a tune-up. You don't have to, it's not like an oil change, you have to go every 5,000. A tune-up is 100,000. So the athletes would ask me, and I said, because I've worked with them, it's good for 8 months. If you're an athlete, it may, you may shorten that time, but it's 8 months. The psoas, so what does the psoas do? So I would come for the combine. I can get you, we could test you. Come over here.
We can't figure out why the psoas wakes him up at 4 a.m. every morning.
It's what?
The psoas wakes him up at 4 a.m. every morning.
Like a grip, it's pain, but I'm awake.
Well, it's okay. I need you to jump. So we'll have you jump. No, we're going to use one table. But so I want you to jump as high as you can, and we try to spot how high you jumped. Give me 3 jumps, as high as you can go. I'm just showing you what psoas to do for athletes. All right, so go again. Go again. Now really try as hard as you can. Go again.
Try my other arm?
Well, no, the same arm. No, the same arm. Keep going, just as high as you can. All right, so you guys saw where it is? All right. So there was a seminar one time, so a guy would put $1 up, and he said, jump for it. They all jump, and they got it. He says, can you go any higher? No, they couldn't. Then he put a $10 one up there, 2 inches higher, and made them jump, and they all got the $10 one. So,
Have shoulder problems. They can't lift like 20 and say, come on, reach higher.
all right, so here. This is my technique, okay? So I'm gonna have you lay down, put the corner of the table between your legs, and lay down with your head facing to the right.
Pants on, Greg.
Let's ask your wife. You want to do this with pants on or pants off? I have gloves.
Let me see your fingers. No, it's
I could double glove. All right.
Does the head turn matter?
Yes.
So if it's the left side, turn right?
I want you to turn to the right, yeah. So he's laying down. Now, what I want to tell him is I just want you to toe touch. So toe touch both, okay? So I want all your weight here. All right, so I want a flat.
You did this 3 times.
You screamed like a pig. Brings your trauma because it was the psoas. All right, so I'm going to do his left leg. So what I'm going to do is I'm going to take his leg. I usually just support it here so I can grab underneath the distal femur. So balance yourself in the middle. Okay. I'm going to put my hand on the crease on the just lateral to the crease. So I got his SI, I got the ilium, and I have his muscle. So what I'm going to do is, he's going to help me with it. That'd be the easiest way to do it. So when you're going to take a deep breath, as you start to exhale, you're going to lift your legs straight up this way, up, like you're going to go rhythmic up, not kick it or anything, just bring it up. So I want to deactivate the muscle, take a deep breath, bring it up. I want him to start, and I pull it up. And what I'm looking for is I want to get to neutral or 10 or 20 degrees above neutral, okay? So take a deep breath, breathe out. Is this the one that wakes you?
Yeah.
Okay, so it's tight. Take a deep breath, breathe out, lift. Again, breathe out. Again, lift it up. All right, take a deep breath. Now I'm going to come out 15 degrees to stretch out the distal attachment. Take a deep breath, breathe out. So I'm trying to get some of the iliacus. Take a deep breath, breathe out. Again, do your work yourself, bring it up. One more time, and go back in the middle. So you see where we are. All right. He's going to tell you how he feels when he walks. So tell me how you feel compared to the side that didn't work on. You feel lighter. Feels like all the pressure, you feel like you're walking, like you're light. But what happens when you do the psoas stretch, you jam up the SI. So I used to do psoas stretch, and then I figured out I was jamming the SI. So you feel the difference, right? Now we'll do the other one. Same position. Turn the head the other way. Now, I'll stand from the same position because I like to do this. I like to put my leg here because I could put my knee under his thigh, so he doesn't activate his hamstrings. So now I know he's just toe touching because I got him locked. Gives me a chance to come here, take a deep breath, breathe out and lift it up. Again, breathe out. Take a deep breath, lift it up. Again, breathe out. Again, breathe out. Breathe out.
That one feels tighter.
No, this one was tighter from the start. That one got tighter at end range. But you feel different. You feel like you could run, you could do anything. When you get it done to yourself, it's amazing. Now watch what happens. Lay on your back. Yeah, on your back.
I'm just curious about what the effects of PTSD.
When you do this technique, they'll bawl. They'll cry.
Or the one you're about to do?
No, the one I did. If they had post-traumatic event.
Yeah, that's why I was interested in having it done to me to see.
We don't want you to cry.
There are worse things.
Okay. So now bend your knee. You're going to see his SIs were in. Now they're not going to be. Turn your leg in. They're out. Turn them out. They're out. So once you do the psoas stretch, SIs are all out. You have to repeat this SI sequence. You see it? So sometimes if you go get a massage or something, they put you out. Relax. Bend your knee. Turn it in. Turn it out. There. There you go. Now we're going to have you jump. I didn't follow it, but do you guys remember where he jumped? Okay. Now make me look good. All right, so jump, squat, and jump up. Did he? But 2 inches higher in the NFL Combine is millions of dollars. Seriously. If you go 38 compared to a 40 vertical jump, $1 million. Because what they're saying is your quickness, your ability to jump is, because now I just put it into a natural position, you could fire your psoas, you could run faster. Except never do a psoas stretch the day of the event, because it fatigues real quick. It'll fatigue.
So how much time do you want in between a day or two?
I would say 2 or 3 days. So I did the St. Louis Blues team. And I got invited to treat them, right? So I did a whole bunch of psoas stretches. They felt great. Doc, I feel great. First period, they were doing 30-second shifts because they were fatigued. I was like, ee. So never do it. I should have bet on the game that they'd lose. All right, who else wanted something? All right, so lay down.
That's the lecture I had to give when I was a resident.
How long are we staying?
10 a.m. tomorrow.
All right, so you got a leg length problem off the bat. So you do have a problem with your SIs. Turn your leg. Which one's shorter is the right one's shorter. Turn your leg flat. It doesn't go flat. This one does go flat. This one doesn't. All right, turn your feet in. So you were a slow runner. Because even at old age, at 65-year-olds, I could see by their motion, I could say you were, and he goes, how do you know? I said, you turn their feet, for men, you turn their feet in. And if their foot can go past 60 to 70, the more they can go, and the more rounded their pelvis is, they could fly.
How about women?
Women have a different pelvis. You can't gauge it.
Okay.
Because all women will go 80. Even you'll go 80. Every single woman will go 80. And women, I can't estimate because of the femoral
That's
angle.
what I was wondering.
Yeah. Bend your knee. Turn your leg in. That's not too bad. Turn it out. You're stuck. But I also showed you between when I was playing around with him, you could put it in yourself. You saw me put it in. I was the worst. I couldn't get to neutral. I was 10 degrees shy of neutral. You can do it yourself, but it comes right back. It doesn't stay. Here, he's stuck too. Let's see here how your femorals are. So I look at the pants. I look for symmetry. And And it seems like he rides a little this way. But see, this one glides nice, so you don't see much movement here. I'm just trying to give you easy things to look at. Okay, so, all right, let's see how your calcaneus. There it goes, there's one. So this is my best move, is my calcaneus, because I can get tib-fib joints, I can get a whole bunch of stuff in place. You're stuck here in this ankle. All right, Tom, let's do the femoral head on him, since he's in this position.